And we're back with CareCast, and we're going to continue the conversation we left off from last time, reviewing all about what hydrocephalus treatments are and all about shunts.
Christoph, this next question is for you. Is one shunt the same as all of the other shunts? Are they all work just like a faucet like that? Or what's the difference, if there are any, between different types of shunts?
I would say, from my point of view, with my background, it's very interesting. If you consider medical devices, you will hardly find a field where the proposals are so different, like they are in this shunt treatment or in this hydrocephalus treatment. So, let's say with cars are looking somehow a little bit similar, all the wheels and so on. If you look about shunts and talk about shunts, the technology behind how it works is significantly different from one valve to the other, or there are different groups. But this is, by the way, the background why I founded my company, because the interpretation of what is required is not seen in the same way like we did and like I do today. And this offered a lot of opportunities to improve the situation, and this is based on different technology.
So we've heard of conventional shunts, Christoph. We've heard of gravitational shunts. What would be some differences between those two types of shunts?
I would try briefly to explain a little bit the situation. We talked about the pressure situation in our brain, which means, well, at the moment I'm standing here, the pressure situation which keeps my brain is located within the bone, let's say, has a very limited range, which is acceptable for us. Yeah, if you have a water bath and you dive 10 centimeter, this is the pressure we have here in our brain at the moment. What you would feel if you're diving, not 1 meter, just 10 centimeters. And if this is going to be too high, to 20 centimeters below the surface, this is a measure how to measure the pressure in the brain. Then it's going to be dangerous and damaging the brain itself. So, and if you don't have hydrocephalus, this pressure is carefully controlled by the physiology of our human body. And if this is disturbed for whatever reasons, then we implant this artificial drainage. And now the job for the valve is to control the situation. A conventional valve just says, well, from inside there's a pressure. If it's too high, it opens and it drains. But with this conventional valves, the posture-dependent situation is forgotten, which means, well, now it's turning a little bit in a physical situation. I try to make it simple, but if we are lying, head and the peritoneum on the same level, if we are standing, the head is above and the peritoneum is below, and the valve should act regarding the position of the patient. And this has been ignored, for many, many years. And when I started working on my valves, we focused simply on this aspect. And well, there are different philosophies just to control the flow, or just having one pressure range. So we say we should have a posture-dependent valve. And this is a gravitational valve.
A posture-dependent valve. And these are, correct me, Christoph, are these the valves that you can adjust how much pressure they relieve depending on the posture?
This is the second aspect. When we started, people were looking at conventional adjustable valves, ignoring the situation that the valves should be adjusted in the morning and the evening if the patient is getting up or lying down again. But this is only done in the hospital, not possible to do it on a daily basis. And we said, well, sure, we would like to have a valve which automatically adjusts depending on the posture. And then in addition to that, we have now two options. One, to adjust the reasonable pressure individually for the upright position, and the other one for the lying position. So we can carefully individually adjust the optimal pressure with these two different adjustment units.
And how do you adjust that pressure, Christoph? How is it adjusted?
Well, there is only one method which is used by all the different manufacturers. So we do, within the valve chambers which are implanted, they're integrated some magnets, and they can communicate with the magnet outside and do position the magnet above the valve, if it's, for example, placed here, and turn something, and so the valves are going to be readjusted. But this partially is a little bit tricky because, well, everybody's dealing here and there with magnets, right? So we know the magnets from the fridge, for example, And even these magnets might change the valve if there's not a brake included. And so now it's turning more and more in the direction of technology. We, for example, developed something which is not adjustable due to such circumstance. That if children are playing with toys, partially including magnets, and this happened, reported in scientific literature that this happens, they were playing and then the valve was readjusted and leading to difficult clinical situations. So the adjustment is somewhat tricky, and especially for MRI investigations, they should have a brake that it's not readjusted during this investigation, which is very, very often performed.
I had no idea. I had no idea there were magnets inside of shunts, Tim.
You know what? I had a clue, Amy. We had seen the magnets when I was at the bedside. We used them. I never really knew what they did, if that makes sense. Like we never did any of the adjustments. They were there and we talked about them, but I never fully understand it until Christoph just explained it. So that was very helpful. And I guess that's one of the key considerations, making sure there's not, minimizing that other magnets, not the, the ones that are supposed to adjust that are good, and other magnets, we want to avoid those to avoid any sequelae from that, right?
Well, yeah, you guys said that simple magnets from the fridge could interfere with the settings of a shunt. That's incredible. I had absolutely no idea. So when following up with that, talking about magnets and interference and changing the settings is the only reason we're changing settings of the shunt for position. What are some other reasons we might need to be changing the position or the settings on a shunt?
I'd like to answer this question for sure.
Please.
We are different. I would say basically we're all the same, but in the other way we are different, which means, well, we are all human beings and we have a brain and eyes and a nose, but we have different distances, for example, from the head to the peritoneal cavity. Well, if you're a little bit taller, maybe it might be 30 centimeter or 40 centimeter. If children are growing, well, babies are very small and they have a shunt. And if they are growing, then the shunt should be adapted to the growth of the child. And this is one reason. The other thing is that the position of the peritoneal pressure, where the CSF is going to be drained, the pressure situation is not always exactly the same. And if you have a chance to individually change the setting of the valve, you can optimize the clinical outcome, the clinical situation, the perspective of the patient. And this is very often performed by neurologists who talk with the patient. Again, it depends a little bit if we're talking about patients with abnormal pressure hydrocephalus or children. They have different problems, but having the chance non-invasively to interfere with the clinical situation has very, very high value and an enormous importance for the treatment after the shunt has been implanted.
All right, Kelly, from your perspective, I mean, it sounds like when patient has hydrocephalus, if they have a shunt in place, I imagine most of the time everything's going okay. I mean, 99% of the time things are okay. But when there is a malfunction, when there is an adjustment required, what might be some signs and symptoms that care is required for that shunt?
Certainly. So post-operatively, the goal is a positive clinical outcome is those signs and symptoms that the patient had preoperatively, they're going to begin to improve. The patient's going to become more active and alert. And from a pediatric standpoint, the patient is going to become less fussy. If some of those symptoms start worsening and the patient is there in the clinic for just a follow-up appointment, then the neurosurgeon is going to take all of that feedback from the patient and the family, and then make a decision along with if there has been any recent imaging done to see what the ventricles look like. And then from there, make a decision as to what adjustment should be performed on that patient. So with an adjustable valve, the neurosurgeon really has the ability to tailor the settings on an ongoing basis as the patient's clinical needs dictate.
Awesome.
That's great. So that's just after surgery, correct? So let's say the patient's been living with the shunt for a few years. I'm working in the emergency department and the patient comes in, what are some signs and symptoms that I would see if I didn't even know that they had a shunt until they're telling me, or if they do have a shunt and they're telling me they're having these symptoms? What are some things to be on the lookout for VP shunt malfunction?
Typically, yes. So the most common cause for a malfunction is an obstruction somewhere within that VP shunt system. So
Okay.
from the entry tip that's in the ventricles to the exit tip that's in the peritoneal cavity, there's some type of impedance of flow. And with that impedance of flow, hydrocephalus signs and symptoms are going to start recurring. So again, just the patient's clinical picture, what is the trajectory? Are those signs and symptoms worsening? Are they improving? And if they are worsening, then you know, what has occurred clinically that has brought the patient to the ER? And of course, in tandem with imaging, they're going to be able to see a clearer picture. Another complication is some type of infection. So, of course, just the typical signs and symptoms of infection, a fever, redness and swelling and tenderness along the shunt track. And then if it's in the immediate post-op period, those same sorts of things around the incision lines as well.
Thank you.
Amy, our directors are giving us the wrap it up signal here, and I do want to give our special guests a quick second here. So I'm going to jump in. Christoph, Kelly, before we close out, as we head into Hydrocephalus Awareness Month, is there anything that you would like to share with our listeners? And Christoph, I'll throw it over to yourself first.
Well, my message is, you know, I'm very thankful for having the opportunity to invite everybody to think about this somewhat a little bit strange and not very well known entity. You know, hydrocephalus is not, let's say, something with the heart, and very limited people are suffering from hydrocephalus. But it's very, very important. I learned it personally over the last 28 years that to focus on technology, which is developed for these patients, is very, very, very important. And it's not all about just having a company running. The passion behind saying, well, we listen to patients and we share thoughts and we bring our expertise together is so strong to lead to new conclusions. And at the end, it's then our responsibility to bring new proposals to improve the perspective for patients. And I'm very thankful for having had the chance to participate on such a project. Because very briefly, very recently, again, I got the feedback from patients simply delivering a message saying, well, this changed my life. And everybody can easily understand what this means to an engineer being responsible for this type of work. So the focus is the effort works, and we should continue to work together and improve the situation for these people.
Awesome. Thank you, Christoph. Kelly?
Yes, from a nursing standpoint, I think it's crucial for nurses in general or anybody in the healthcare field to realize that it's a lifelong journey, and it's important to guide the patient and their family towards the myriad of resources for support and education and just advocacy. Since it is a lifelong journey, the patient and their family really need to develop a solid foundation of knowledge. And then on top of that, a very strong support system within the family, the local community, and even nationally, so that they too can become an advocate of the condition.
Awesome.
Thank
Kelly,
you, guys. Thank you
Christoph,
so much.
thanks so much. And we really also want to thank our partners over at Aesculap for helping us put on this this CareCast. Amy, I'll hand it over to you.
Thank you guys so much. And if you didn't notice, we wore our blue for Hydrocephalus Awareness Month. That's right. Thanks, Tim, for doing that. So anyways, guys, if you would like, please check out these partner websites for us. Aesculap, www.aesculapusa.com/hydrocephalus. And please check out Dr. Mitke's website. We're going to display both of them below. If you'd like to learn more about VP shunts, please go to those websites for us. Thanks for joining CareCast. I'm Amy Bischke.
And I'm Tim Cavanaugh.
We'll see you next time.
Good to see you.
Thank you.